In this video, we will review the anatomy of the dog knee, followed by a step-by-step look at the TPLO surgery. For the anatomy, first, the femur in blue. Next, the tibia, the patella, the patellar ligament, the fibula, and from the back of the knee, we'll look at the medial collateral ligament, lateral collateral ligament, the caudal cruciate ligament, and then the medial and lateral menisci. And our main focus, the cranial cruciate ligament. This term is synonymous with the human anatomical term anterior cruciate ligament. The blue arrows represent forces that the dog knee sees throughout running and range of motion. As the force goes through the knee, the menisci distribute that force over the tibia and protect the cartilage. In most cases, due to multiple factors likely based in genetics, the dog experiences a progressive tearing of their cranial cruciate ligament. Little by little, the microtrauma tears away at the ligament until finally the last strand of the ligament breaks and the dog's knee becomes unstable. The instability that results from the CCL tear causes what we call cranial tibial thrust. This results in additional injury to the dog's knee and arthritis formation. You can see in red a depiction of the meniscus becoming injured along with the bony osteophytes on the femur and the medial buttress next to the medial collateral ligament. The medial meniscus is especially injured during this motion. To eliminate this cranial tibial thrust, the tibial plateau leveling osteotomy is performed. Pre-surgical planning takes place based on x-rays. Lines are drawn on the digital x-ray film through the joint above and below. Another line perpendicular to this. And finally, the tibial plateau slope is estimated as seen with the blue line. This produces a tibial plateau angle. Here, it is shown at 29 degrees. The surgery will correct this angle and thus eliminate thrust. We make a skin incision over the medial aspect of the proximal tibia. This incision allows for us to access the top of the tibia. A special blade is used to avoid excessive trauma when cutting the bone. This blade is planned for and then carefully inserted, and the tibial osteotomy is performed. Next, a stainless steel pin is inserted in the proximal osteotomy segment and used to leverage the proximal segment until the desired tibial plateau slope is achieved. After that, a second pin is passed through both segments to stabilize this new position for bone plate placement. To anchor the bone plate into the tibia, we use locking bone screws for stability and non-locking bone screws for compression of the osteotomy. Here, a non-locking screw is shown with the ability to move. This allows for compression. As a locking bone screw inserts into the plate, the head of the screw threads into the plate and locks in place for strength. Here you can see the non-locking screw moving on the right and the locking screw on the left fixed in place. The bone plate is applied to the tibia in order to maintain this new level plateau. The screws can be applied differently according to surgeon preference. Once applied, the anti-rotational pin can be removed. It is normal for the screws to stick out slightly from the bone. This new tibial plateau angle of around 5 degrees or less allows for stability of the knee to be achieved. Now, as forces go through the dog knee, there is no longer cranial tibial thrust. Existing arthritis cannot be removed. However, this new stability will reduce progression of future arthritis.